everybody. I know we're just a few minutes early. I appreciate the folks that are early birds. Just taking a minute here to get everything working on my side. Oh, let's see. Does it to me every time. There we go. Makes my screen small and then it's hard to keep an eye on everything, but I got it this time. Hey, Jessica, can you confirm that you're seeing my screen okay? Oh, okay. Thank you, Jessica. Welcome, everyone. Obviously, it takes a few minutes for everyone to get logged in. Thank you for joining us. I did put in the chat, for those of you who are kind of waiting to get started, it would be great if you could take a few minutes in the chat, introduce yourself to the group. And I would really love to also understand how your particular organization might interact with the CMS Access program. Are you a provider organization thinking about joining the program? Are you a potential referring provider, like a primary care or otherwise referring provider to refer to other access participants? Are you a health tech enabler and are kind of excited about the ability to get on the CMS website for that? I know we had a number of folks from HIEs registered. Are you with an HIE? Because obviously, healthcare data sharing is an important part of this program. So, you know, look forward to seeing your chats as we proceed here. All right, we are at top of the hour. I usually give just a couple of minutes because we typically have a kind of a rush here at the beginning. Thank you, Mark, for going ahead and starting the introduce yourself chat. Appreciate that. The other thing I'll say, and I appreciate Mark for doing so, we love it, and I see other people turning their cameras on. We love to see your faces. Hi, Mike. Good to see you. It's actually a little easier for me to kind of quickly see folks and see who's on the call. Love the video if you can do it. I do understand that some folks eat lunch or do other things during this calls. It may not want to turn your camera on, but we love it when you do. Yes, hi Mike, great to see you. Uh, oh, Elil, and I may not be pronouncing your name correctly. Um, Great. Russ has got a comment in there. Uh, all right. Well, fantastic. Just doing a quick scan here. So, so we have Laurie Peters says that she's with potentially a health tech enabler. Ruth is with IMAT, so that would be another health tech enabler type company. Mike, the interface guy at Reliance, represents a regional HIE who could be supporting access participants in their community. And let's see, Russ says, I want to understand issues that are related to interoperability, especially in healthcare. Also, might be doing some work on some of these initiatives. Great, Russ. Yeah, we're going to focus this particular conversation today around this special CMS access program and what kind of interoperability requirements are required there. And Scott with my directives in Dallas. Scott, I'd love to hear as we get further into this conversation your perspective on if how advanced directives kind of come into play with some of, if you've had any conversations or thoughts around how what you guys do might relate to supporting this access program in terms of letting patients' wishes be known. Certainly, the biggest group out is, people, could be some pretty serious chronic illnesses that people might have. Shelby with MyHin, another HIE friend, fantastic. Joel with Ohio Community Health Center is fantastic. Mike with a HIE platform company, another tech enabler, so fantastic. And then another Washington HIE, so fantastic. Well, I'll go ahead and get started. It's good to know who I'm speaking with. Really appreciate y'all coming today. So we'll go ahead and get moving. So whenever I do these, I always have an audience that really runs the gamut in terms of their level of understanding of the topic that we're talking about, from people that are just really curious and haven't really had a chance to spend a lot of time researching the topic, or some folks are going to bring a lot of knowledge, and I hope that they and I got to look at the guest list, people who enrolled. We certainly have some very knowledgeable people attending that I know probably have done a lot more research than me. So I'm going to try to find that balance between, giving some basics and kind of pointing people to some good additional resources, as well as diving in maybe a little bit more deeply than you've had time to personally. So just first of all, what is the CMS Access Program? So this program was announced last year, kind of the second half of the year, by CMS. And it is designed to test an outcome-aligned payment approach in original Medicare. So this is not a Medicare Advantage program yet. It is specifically designed for those of us, I happen to be one, who are on traditional Medicare. And the concept here is expand access to new technology-supported care options that help people improve their health and prevent and manage chronic illness. It's a voluntary model. It focuses on some conditions that affect more than 2/3 of people with Medicare. And we'll talk more about those conditions. And it is planned to be a 10-year program. Providers can start applying now, but it kicks off, the first 12-month period kicks off in July 5th of this year. And I did include there a link to this document, and I found this document really helpful as I was preparing for this session. It's called the Request for Applications document. It's long, but it has a lot of really good detailed information, including it kind of explaining the online form. So for anybody who is or knows someone who, as a provider organization that's going to be applying, it kind of walks through each of the questions that are included in the online form, which is really good to look at ahead of time, I think. And then Jessica, I'm going to ask you as we proceed along, if you can just interrupt me, give me a little heads up if we've got a question as we kind of transition from section to section here. That would be very helpful. I'd appreciate that. So we'll keep going here. So I think one of the most important things to understand is, well, who can be an access participant? And it's really pretty straightforward. Number one, only Medicare Part B providers are eligible. So that would be any existing Medicare Part B providers, or maybe new organizations that are getting formed who are then applying to become a Medicare Part B provider. Now, you can't apply for access until you've gotten accepted under Medicare Part B, but don't be surprised if you see some new kinds of organizations spinning up to participate in this program. One of the second major requirements is you must provide technology-enabled chronic care program or chronic care services. And this program puts a big emphasis on technology. We'll talk more about that also coming up. And then finally, the organization that is applying to be an access provider, for the people enrolled in the access program, you can only bill under the Access program for if you're a provider organization and you're a Access participant specifically, any of your patients that have enrolled in the Access program, you cannot bill fee for service during the time that they're in the program. So that's just kind of an important thing to watch for, and I'm sure will definitely, have an impact on people's decision making here. I actually see a question that does this apply to tech-enabled chronic behavioral health or behavioral health coverage for chronic medical conditions? What I can tell you, and I'm definitely not an expert on all of the detailed chronic conditions, but it does specifically call out a behavioral health track as one of the early conditions that they are interested in and helping improve outcomes on. All right. So that kind of sets up the who's going to be actually applying. I definitely had some tech vendors ask me, well, should we apply? And the answer is, well, no, you are not a Medicare Part B provider. Now, there are some Medicare Part B providers that may have embedded or created their own technology that they're using to support this program. But the big key requirement is you've got to be a covered entity, and specifically you have to be a Medicare Part B provider. All right, so now it gives some examples of, what it kind of expects for these provider organizations that apply and get accepted into the Access program. And obviously, it's emphasizing outcomes rather than a specific set of activities. However, there are, it does provide some examples of the types of proactive care management that might be tech-enabled that it is expecting to see for the people applying and engaging with those enrolled beneficiaries. And I would say one of the things that's important is this definitely brings in a telehealth component, because it talks at the bottom here that these services can be delivered in person, virtually, asynchronously, or through other tech-enabled modalities. So it's giving a lot of flexibility as to how care is delivered. It does have a potential for supporting remote monitoring, using digital devices. It actually kind of, there is a complementary program called, I think it's called Tempo. I'm not going to spend time diving into that today, but it relates to FDA type devices that fall under the FDA, and how it might kind of jumpstart the ability of those device companies to kind of get an opportunity to maybe do things sooner rather than later, which is interesting. So this is, I thought, just a very useful listing of the types of things that these Access participants, the types of care services they might provide. So one of my first questions to the group is who feels that all of the buzz around the tech component here might be overblown? I'm just really curious. I mean, obviously, we work a lot with health tech vendors, but we work with a lot of other types of organizations also. And so I want to keep an open mind. I am curious if anyone on the call has a strong opinion about thinking that, well, for example, if you look at the application itself, it does ask how you're using technology. Question 24 says, how is your organization going to be using or will plans to use tech to enable care for these chronic illnesses? But it also says then you can say NA at the bottom, like, I'm not going to use tech. I don't know what happens if you mark NA. Is that like an automatic disqualifier? It doesn't say it is. But clearly, there's a lot of emphasis on technology if you read all of the information. So does anyone, I'd love it, feel free to just turn off your microphone and start talking if you have an opinion on the tech side of this particular program.
Hey Marilee, it's Scott. How are you?
Hey, Scott, I'm so glad that you are speaking up because I might have called on you otherwise.
It's fine. It's fine.
Yeah.
No, look, we talk to CMS on a regular basis, and everything they're pointing to is about technology and the exchange of data, and whether it's advanced care planning data and longitudinal, care and these kinds of things. I don't think the tech element of it is overblown at all, because this is the way they're moving. And if you looked at their ECQMs, the measures under consideration, everything they're doing is pointing to the use of technology to enhance the care. It's no longer about, hey, are you recording things and keeping them in your EHR? It's, hey, are you recording things and are they actually affecting care, and how are you exchanging it, and all those things. So what we're seeing and what we're talking to ASTP and CMS about, it's not it's not overblown at all. It's going to be about the technology.
Well, that's a great perspective, Scott. And one of the things that I was thinking about as I was preparing for this and looking at the requirements, and we're going to talk more about the payment model and some interesting things about it. I would even say the payment model has some little tiny poison pills built into it that might dissuade people from joining, as much as I'm excited about this program at a holistic level. But what kind of dawned on me is like, I literally don't know how you would do this without technology. I think certainly from a delivering, the interoperability side, Scott, to your point, but and the reporting requirements and those kind of things. But I also think just in terms of how you're engaging with patients, because, the most expensive way of doing anything is with people. And so I think the way this program is structured and the way the payments are structured, if you're not really using technology to help facilitate that interaction with the patient in a very cost efficient way, it might be pretty difficult to have the impact on outcomes like you're trying to have in a way that is kind of makes the whole thing work from a financial perspective. Anyone else have maybe the contrary opinion or want to weigh in on this question? All right, we will keep going. All right. So what about those other providers that maybe don't feel like they want to enroll in the Access program as a participating provider, but want to refer people over to the Access participants in their communities in order to just help their patients? What's in it for you? And so I will say, and I'm going to show a visual here in a little bit. Primary care physicians and or specialty care physicians who are referring over to the Access program, you play a very important role, in the management in this program. And to reward you for that, there is a little bit of an extra fee that you can collect. And for you, this is on top of your normal fee for service that you're doing. There is no restriction if you're just referring people over, but you can bill a special code which is an Access Model co-management service for documented review of the Access updates that you're getting from your Access participants, because that's a requirement that they're updating you about what's going on with those patients. And that you may have heard about this $100 a year number, and that's what this represents. And I'm going to walk you through the math on that. And then one just little side note, there's quite a bit of language in some of the FAQs around referring people, if you're not directly participating, referring them out to other Access participants. And so just understand that there is some legal requirements about self-referrals. That's kind of just the typical self-referral prohibitions that exist in healthcare, but it's just something to keep in mind. So let's look at that co-management fee and how it works. So, and I've got quite a few details here, and this will be useful, I think, for those of you who request a copy of this presentation. But if you look at the bottom, we can just cut to the chase. You can bill $30 for every person that you're referring over, every Medicare beneficiary to an Access provider. You can do that 3 times during the year, so every 4 months. And then there's this, and you can also bill an extra $10 to help facilitate just the referral process itself. And so that's where you get that it's 30 times 3, which is 90, plus 10 is $100 a year. That's where that number comes from. And this is a number that I've seen, I think has confused some people that are thinking maybe that is the OAP payment, but this is the co-management payment for providers who are simply referring patients to an access provider. For access providers themselves, what we're really doing is replacing traditional fee-for-service billing for this payment that they're calling the OAP payment, which is similar maybe to a kind of capitation payment. If we think managed care, they have not published the fees for this. So I think that's an important thing to note. I am going to pause also here and see if anyone has any interesting insights or commentary around the potential fees here, because they're saying they will announce this prior to April. So in April, is when you can start applying for the program. Or I guess, no, you can start applying now, but the first cohort runs between January and April. But obviously, big missing piece right now, because there is no published rates for the access participants. So curious, anyone have had any discussions with the CMS or listened in on any interesting conversations of what those payments might look like, or if they might be comparative to something else that we are familiar with, like a payment under Medicare Advantage or something? Any thoughts? No one's found any information that I couldn't find. Well, that's a bummer, but that's okay. I think the clear thing is they will be making those announcements here soon. I would expect to see them, hopefully in February or March. I have seen some pretty good detailed information available with more information getting added. So it feels like they're moving at a pretty good pace. So just to kind of quickly summarize what we do know about these OAP payments, the first year payment will be higher because it's incorporating the fact that you're doing your initial enrollment and assessment in that first year. And the second and subsequent years would be lower because they're assuming that you've already got the patient, you've already got the inpatient engaged, and therefore your cost will be lower. And then whatever the full payment amount is when that gets announced, the full payment is, of course, because it's an outcome-based payment, is going to be contingent on achieving your OAP measure target. And there's some really interesting examples, and I didn't put them in here because I felt like we wouldn't have enough time. But if you go to the document that I think we posted it in the chat, the document link that links to the CMS website. There is some good examples of how payments might look like based on, the outcomes. There is, in the first year, there is a 50% cap on the payment reduction for outcomes. So they are limiting how much they can penalize people for not achieving the outcome measures. And then I think that cap is a little bit less in people's favor in year 2. The other interesting one, and I mentioned what I would consider a tiny little bit of a poison pill in here, or something that's going to give people some pain. So maybe I'll even turn this. I don't have red. I was going to look for red here. But what's interesting here is that you can bill your access codes monthly. They will pay you a quarterly fee based on everything that they collected from you in that quarter, but they're only going to pay you 50% of the total OAP payment for that particular chronic illness group. And they're holding back 50% to do a reconciliation process at the end of 12 months. And what they're really doing there is holding out, this whole emphasis on outcomes. They're not wanting to pay and then take back money. And so this allows them to do the reconciliation, and then you will get basically whatever that gap is. You'll either get the full 100% if you've checked all the boxes and achieved and jumped over the thresholds, or they will discount it in the way it's appropriate through the program, and then send you the balance of that at the end of the 12-month period. So one of the interesting commentaries I've seen is that for organizations signing up, there certainly is a pretty significant capital requirement, knowing that you're going to be providing services over time, but your full payment for each one of those eligible patients or enrolled patients won't be forthcoming until we get to the end of the year. I'm really curious people's thoughts on that. How much do you think that's going to be a disincentive? And I know we've got some HIE folks. I'd love to hear from some of the folks that are maybe out there talking to provider organizations in your community, what their thoughts are about this. Anyone got any thoughts?
So Marilee, this is Eliel here in Austin. So I'm thinking that it may depend on, the technology tool specifically for a specific care or condition that's going to be addressed through the program, and what risk is involved to the providers, right? So I'll give an example. Let's say behavioral health are going to be using, a tool that could get reimbursed. Would that vendor, be willing to take on the risk as well to basically say, you get 10% of our payment, and that means 10% of that 50%. And then if we get paid and the outcomes are achieved, you get paid again later. So I think there could be all kinds of variations there, but I think a deciding point for providers will be how all these different tech solutions will be able to negotiate.
That's a very interesting point, and an interesting possible business model for some of the tech vendors on the call that are going to really be enabling the chronic care management. I know there's some one of the articles that we actually put on our blog, and I think I mentioned it down below here. About this, I thought it goes into a ton of detail and has a whole section around for investors and the kinds of things they should be thinking about. I think those groups that are fairly mature or have strong backing or are in a position to take on some of that risk will be well positioned. Anyone else have thoughts on the 50% holdback for the end of the year? Or 12-month period, it doesn't necessarily have to be a year. All right.
Well, quick question for you. So with the outcome payments, will CPT code reimbursement still be a viable option then for our remote patient monitoring?
Yeah, you cannot be, and let's see, I think I talk about this. So you can be, individual patients can be enrolled in multiple tracks.
Mm-hmm.
But you cannot bill fee for service for patients who are enrolled in the program. So while they're enrolled in the program. So it's from my interpretation, and again, if someone feels differently, please jump in. For those patients who are enrolled in the ACCESS program, you cannot bill typical fee-for-service codes during the time when that beneficiary is in. Now, it doesn't mean that you can't have patients outside the ACCESS program. So you definitely could have scenarios where you have providers who take on risk and have a mixed patient population where some of them may be joining ACCESS as a participant, and in that case, you can't bill fee for service for that patient during their time they're in that particular ACCESS program. But you could have other patients that are not enrolled in the program, and there you can bill traditional Medicare fee for service claims. So it's really, you have to look at it on a per beneficiary basis, and what really matters is Are you an access provider? Number one, did you sign up? And two, are you then, do you have a population of people who are not signed up where you could bill fee for service?
Yeah.
Yeah.
Okay. Thank you.
Just making sure we're not skipping anything. Okay. So the target population, I think we kind of covered already. It's traditional Medicare patients with designated chronic illnesses. And let's talk about what those chronic illnesses are. So we have early cardio, kidney, metabolic disorders, and they give some examples here: hypertension, abnormal or elevated lipids, obesity or overweight, and pre-diabetes. So obviously a pretty large contingent of people to work with. And then you have your cardio, kidney, metabolic chronic illnesses, diabetes, chronic kidney disease, other, and I can't, atherosclerotic cardiovascular disease. So again, another big contingent. Musculoskeletal. I can't say these words. I just need to stick to interoperability. I can say those words. Chronic muscle pain. This one has got my attention. I'm pretty plugged into the fibromyalgia community, and it feels to me like fibromyalgia would fall under that setting. And I know that's an example of a condition where there's a lot of, whether I won't say there's a lot of, there are some good telehealth groups available to help people manage their fibromyalgia pain. So that's one that's got my curiosity. And then we talked about behavioral health and managing depression or anxiety. Happy to have people drop in if you have any specific comments about any one of these specific conditions. I think that if you look at a lot of, like if you go to Vive and Health and you look at a lot of digital health apps, many of them are helping patients manage these types of chronic illnesses. Blood pressure, certainly, obesity, diabetes. There's a lot of tech that is very specialized on certain chronic illnesses or a family of chronic illnesses. And then, and certainly behavioral health, I think, falls in that same category. And in our situations where, virtual coaching, either through an app or through direct, virtual interactions with patients, can be really powerful.
So Marilee, I had a question on this. You sent an article that was very helpful talking about the addressable market for each one of those tracks. And I read that article and it talked a lot about maternal health, but I don't see maternal health listed in these groups, right?
Yeah, I'm not sure which article that was. There's quite a few out there. I have seen some as I've dove in that maybe didn't have things exactly right. They also might be referring to what might be coming. CMS is considering adding additional tracks and conditions in the future. And so this is just kind of the first out of the gate. And I would be, unless it's just maybe a complete non-starter, that they just can't get anyone any interest here in this first 6-month period. If they can get any success at all in getting people enrolled, then I would expect to see other tracks and conditions coming on board. Anyone else have been involved in any discussions about other conditions? Well,
Yeah.
we will. I'm sorry, go for it.
I can provide just a little bit of input. I think these are actually quite good. So certainly heart failure comes into play here and it has many different derivatives of it. So it can be valvular disease, or it can be, which is more genetic, but then you have to compensate for that, or it can be atherosclerosis, or it can be related, which is typically combined with obesity, and then also there's you see a decline in respiratory function in combination, right? Because the whole vascular system is just not working up to par. So there, we a lot of these RPM vendors put together programs, and then the programs are designed to, address each set of diseases. And then, of course, the AI can actually do a filtering through the population health database and then determine which patients are candidates of those programs. That's typically the cleanest way to do it. And then,
Yeah, I
of
think
course, the devices match up with the program.
right, right. Yeah, that's a
Yeah.
very good point that we talked about using technology once you have once you have the beneficiaries enrolled, but just getting to the point where you can find the beneficiaries obviously will be an important step. And then I also think, especially since to me, the thing that could really help, and I could be crazy on this, but just thinking about it, the fact that you can't bill for fee for services, that a lot of these patients will be eligible. I mean, how many people have hypertension and diabetes, and low back pain, and depression? So I do
Yeah.
think that the way the in a program that covers all of these conditions and can have patients enrolled in multiple programs, so you get a more holistic health profile of the
Yeah.
patient, is going to be really powerful. And I
Whole
think
person health. Yeah.
makes the revenue, I think improves the revenue. Now they do drop, if you are enrolled in multiple programs, they do drop the fee. They're going to drop the fee a little again, because they figure there's efficiency if you've got one organization managing multiple programs, but you still would, get the benefit of participating in multiple programs.
So a patient can be in more than one program. Yeah,
Yes.
that's really good. Just because it's hard to find one size fits all, given that, these chronic conditions are nested. They call it multi-morbid, but that is the case. Typically, it starts with behavioral health, because the decisions that people, they have chronic conditions for a reason. Generally, there are life choices, stemming from sleep, exercise, stress management, and diet and nutrition. Those are the four pillars that really kind of support the physiological health, and then those decisions can cause the roof to lean one direction or another until it's
Right.
crumbling. But I think that maternal health, I heard that mentioned earlier, really is a big one. I know like states like Georgia have a serious problem around that area. And it's an area that I think that could be highly beneficial. The impact could be also greater because the patients are younger. They have a chance to kind of not only ensure a successful pregnancy, but remap the trajectory of their health long
Yeah.
term, long tail benefit on that.
Yeah, absolutely. And I'm thinking that for anyone going to the ONC, the ASP ONC meeting here coming up in February, maybe it's a good time to do some lobbying around maternal
Mhm.
health. I will be there, so I'm definitely going to pigeonhole a few people and try to ask them about that. But obviously, being able to, I think they will listen, the people at the Dr. Keene, and some of the folks on his team. They have been actively, I know they've been, as Scott has pointed out, they've been very active in our interoperability meetings. And they are making themselves accessible, which is good. And I think so I love the maternal health. And if anyone has any other ones, put them in the chat, and we can carry that information forward.
Yeah, there's the Medical Association of Georgia has a very broad reach to physicians. I think about 8,500, 8,700 docs. They just run a thing called Top Docs, and we've met with the CEO, but you're right about the fact that there needs to be some lobbying, and it needs to be kind of like a politician supported statewide initiative.
Yeah,
But so we've done some there. That's a really good place. I'll put his name in chat for you.
awesome.
Okay.
Thank you. All right. Well, a picture's worth 1,000 words. And this one to me really helped crystallize the requirements and the kind of, and now we're starting to get into what kind of data sharing is required and coordination is required. So I'm going to back up my whiteboard just a little bit so you can hopefully see the full thing. We'll cut the top off here, but we have the access participants. So here's our provider, our Part B Medicare provider who is applied for access and signed up. And then down below in the left-hand corner, you have the primary care or other referring practitioner who might refer a patient to the access participants in their area. And then on the right here, you have the beneficiary, the Medicare, traditional Medicare patient. And so the PCP or referring provider might kind of start the process by referring a patient, although they don't have to be the source of the patient. And you can see that once they do that, there's an obligation to have data sharing happening back to the primary care or referring physician. Once the access participant gets a potential beneficiary, they need to talk to CMS. They need to validate the patient's eligibility through the eligibility API. They need to align the beneficiary, and this simply means making sure that the beneficiary is eligible for this program and is, for example, not part of Medicare Advantage or something. You have the option of receiving claims to help support the care coordination because it is very important what's happening to our beneficiary down here in the bottom right-hand corner when they're not seeing the access participant, because there are some ways that your payment can get lowered, and one of those ways is the beneficiary is off getting duplicate care across other care settings. And so I would say even though it says this is optional, I would say this is going to be a very important component to make sure you really know what's going, even though we know there's this is not the best real-time picture of what's going on with your patient. It's still better than nothing to support care coordination. And then you do need to submit your OAP measures data. And that needs to be pushed via Firebase API to CMS. There are going to be specific G codes. So you will submit claims kind of in the normal way that you would normally do so, but using these G codes that are specific to the Access program. And then you will get your payments coming back quarterly, and we've talked about that. It would be 50% of what the total eligible annual payment might be. So, and I'm going to circle back. I do know there's a question about payment, so I will come back to that here in a minute. And then there's an enrollment process that happens, enroll with the access participants. So there is going to be a directory, a published directory by CMS of all access participants. So it appears as though the patient could actually just sign themselves up potentially right here. And then obviously the beneficiary is actually getting the care. And the primary care physician is getting the benefit of the data sharing that's happening while the beneficiary is in the program that's coming from the access participant, and we're going to dive into that. But this is, again, part of that document that we provided the link to, super helpful visual on what's going on. I'm going to come back to the payment question. There was a question about the $100 per beneficiary per year per track was the question. So the way I understand the co-management part component, which is not for the access participant, that is for the primary care referring provider, that's going to be based on an individual participant basis. I do not think it will matter, and I could be wrong, but I do not think it will matter how many tracks the patient might be enrolled in, because you're managing a patient if you're not a direct, if you're in the position of a primary care physician or referring physician. Now that's different in Access, where you're billing on a per program basis per beneficiary. But I could be wrong, but I'm pretty sure they're saying that fee is capped at $100. And I'm going to open it up. Does anyone else know? Do you think I'm wrong? Do you think I have that correct? Anyone have any thoughts on limitations on that co-management fee?
Marilee, will you be providing this deck
Yes.
to the attendees? Thank you.
Yeah.
Doing a great job, by the way.
Yeah, thank you. We'll at the end we'll put in our email. You can email us, and we will package this up for you. Usually takes us about a day to make it look a little prettier than it does on my screen, and then we'll get it out to you.
So Marilee, I have another question that might help with the one that you just had, which is somewhere in that same article that I put the link here on the chat that I received from you through email. It was talking about the potential this being a $10+ billion a year, right? Opportunity. And I was wondering where the source of that is specifically. And I think based on the size of the population of Medicaid, what that would mean on a per patient, per year, kind of maximum amount to pay, because that could answer the question that we just described here of like, at least for now, since we don't know the rates yet and the codes and all that.
Yeah. And we didn't write the article. It's just one that we saw that looked interesting. So I don't know. My suspicion is they're looking at it feels like they have a very good handle on the size of the population of traditional fee-for-service Medicare patients that have those conditions. I think I read that there's like something like represent like some 60% of all Medicare reimbursement falls underneath people related that have those conditions, and I could be a little low on that. So it's a sizable part of the Medicare spend. And so, given that they didn't, I think what's interesting is they didn't just make this like a 2-year, even though they're saying they're testing a model, they're still saying it's a 10-year program. So it definitely is something that they certainly intend, the current administration certainly intends to try to prove the concept that we can reduce, Medicare spending in traditional Medicare. And also, they're not saying they wouldn't necessarily, this may roll to Medicare Advantage later, but I think they're recognizing that, traditional fee-for-service Medicare, there's not as much opportunity for providers to get incentivized for doing more than just having a patient show up for a visit and you get your visit code and then you're done. And so that, that is certainly part of the equation here. So we've got this recorded, and so I'll certainly do a little bit more homework on that. I think we won't have to wait too much longer before they announce the reimbursement fees, because I think they're going to just not see much traction until they give the full transparency around, the actual reimbursement. People can't make decisions, very effectively without that information. Okay, so now let's talk about the technology and the data exchange requirements. It's interesting because they actually literally say you are not required to use a certified EHR technology as defined by the certified EHR technology program, promoting interoperability program. But they are requiring the specific capabilities around health information exchange and the ability to exchange data. So I thought that was interesting. I guess people could use their regular EMRs, and certainly you've got to be able to document what you're doing. So if you're not using certified technology, you've got to have some way of kind of using it like certified technology. Maybe this is a way of just making sure there's not a blocker for the technology to have to become certified as a certified EMR technology to be able to be used in this program. So that was interesting. So let's jump though into the data exchange requirement. So they're talking about the support for the APIs, which would be patient access and provider to provider exchange. You have to use FHIR to report outcomes data to CMS. This also I thought was interesting. The language right now says you must use the most, quote, current version of USCDI. There are multiple versions of USCDI. The rest of the interoperability world is not using the current. It's back several versions. I think even TUFCA right now, the minimum requirement is still USCDI v1. They're trying to get up a level to keep several levels to kind of improve things. But, traditional EHR technology is lagging behind a little bit in terms of their USCDI support. And this is where, certainly from I know we have a lot of health information exchange friends on this call, establish a connection with a health information exchange. Now, people use the term HIE to mean a lot of things, but I do think it is very notable that they didn't say establish a connection to TEFCA. They said establish a connection to an HIE, and then they even use this language around an HIE aligned with your geography. And I think it is a reflection that it is very different. Some communities have very strong coverage within a geographic area. And we've got a number of HIEs here on the call that provide great coverage for their states or their regions, or in some cases, several states. But there are white areas where, there is no HIE coverage. And so that is where I think the national networks can help, fill those gaps. They do specifically say that some of this sharing of electronic data can be done with direct secure messaging. It's kind of the low-hanging fruit way of pushing data out, to provide those updates. The other interesting things that they say is that query-based exchange is not enough to meet the requirement. So again, I think that, what does that say? It says that if you're a technology provider looking to enable these types of providers, you have to be thinking, well, TUFCA is great, and you should do that. If you ask me, there are other kinds of interoperability that you need to weave in. And certainly, again, kind of a lowest hanging fruit way would be able to move data around through direct secure messaging. I know we have built some automated ways of doing that, so that you're not having to just use an electronic inbox, but you can leverage the technology on your side. You can be kind of sophisticated on your side, but then just push it into the PCPs, EMR if they're not super high tech on their end. Hello. Hi, did someone have a question? We might have just had someone unmute themselves, but if you had a question, feel free to jump back in again.
I do. I don't want to monopolize this, but interoperability is kind of my prior world, and I don't see QHIN on here. Are you including that? Just to kind of do the last mile of connectivity. I see, regional and so I see regional and national HIE. I'm guessing, state is included in that, and then of course the QHINs as part of the TEFCA network. So
yeah, when I say regional, so many of my HIEs cover more than one state. But yes, certainly state HIEs. And when I say national, I'm really talking about the national networks in general. That could be people participating, like a lot of our customers are participating still in carrier quality, because you still have a ton of, that's where the largest number of participants exists today. With more and more people joining a QHIN, with TEFCA kind of being the ultimate replacement of carrier quality, if you will.
Yeah.
But I think what is important to keep in mind is that it can't be the only way you meet the requirements, because they specifically say just doing query only participation, meaning I joined a QHIN, I'm in TUFCA, and I can do query-based exchange because that's the only live exchange purpose that exists today in any of the networks for the most part. There's some experiments happening, not in TEFCA, but in, like, for example, Commonwealth, with data pushes where let's say, you pop out an encounter notification or something, that's been talked about as a possible use case in TEFCA, but it has not been, there's no SOP, there's no implementation guide for that. So that just means I would consider it I think ideally you've got your regional and state HIEs tend to be much better at many ways of sharing data and supporting push models. So I think that's where the HIEs become a really important part of this equation. I think that TEFCA, it's an and to me, right? Join your local HIE, also have the capability of sharing data through TEFCA, because if you look at all of the stakeholders within a geographic area, you're always going to find those people that, well, I'm doing it this way, I'm doing it this way. And so by making sure you can do direct secure messaging, making sure you can do connect with your local HIE, if you have one that aligns with your service area, you might have to connect with a couple of them depending on how much coverage area you have. And then finally, the ability to do the query-based exchange. And then FHIR-based connections for, especially when it comes to reporting, that ability to push that data to CMS for the outcome reporting.
Yeah. Is Zen offering kind of this what Gemini integration as a service platform? So
Yeah.
that's kind of be a kind of something to help with that whole interoperability thing.
Yes, exactly. We are an interoperability platform company. We do a lot of customers use us for direct point-to-point type interfaces. I mentioned the fact that we're able to leverage direct secure messaging in kind of a creative way to help facilitate data exchange. And then finally, we are members of these networks. So we have API-based access to, for example, eHealth Exchange, Care Equality, Commonwealth Alliance, and both eHealth Exchange and Commonwealth are QHINs. And so we are a member of TEFCA through our Commonwealth relationship. Because we're a service adopter there. So it is true that for those people, whether you're a provider organization applying for this program or whether you are a tech that's going to be used by those provider organizations, Zen's platform certainly could come into play. And a lot of our HIEs use us too, which means we become part of the equation there to help connect to the HIEs.
So I see. Thank you for that explanation, Marilee. That was helpful. I see that you guys are your expertise in FHIR, HL7, IHE, HITRUST certified. So if a RPM vendor were to utilize Zen Healthcare IT as the interoperability connection platform, would we inherit your HITRUST your credentials in terms of the movement of the data?
Are you listening in on some of our other conversations around here, Walter? That's funny you asked that. We have another session that we're planning around security and HITRUST and inheritability specifically.
Just I don't know, the Vulcan mind meld here or something.
Yeah. If people are trying to achieve their own HITRUST certification and they're using a vendor like Zen, who is HITRUST CSFR2 certified, and obviously there's different levels with HITRUST, but you can inherit those controls where there's an overlap of some extent, meaning it's a control that has to do with something that we're providing, right? Yeah. So, in the sense that we're protecting the endpoints. We some of our customers log in and use us to help kind of, they do some of their own interface work. They hire our team or they do it themselves. And so they're logging in. So we handle the two-factor authentication. And I could spend all day talking about the different controls that we would have some overlap. And that inheritability then has a percentages. Do you get 25% credit? Do you get 50%, 75%, or 100%? Again, depending upon kind of the role that Zen is playing in that organization's overall scope of their HITRUST certification.
Well, that's very, very helpful. Thank you.
Absolutely. And we'll make sure you get an invite to our security-focused conversation. All right, moving on to, we kind of talked about this whole idea of technology and care coordination. I'm going to drop into that just a little bit. So when we talk about care coordination, who are we coordinating with? What are we sharing with them? And when are we doing that? So that's what we're looking at here. And so first of all, who? So the who are those primary care physicians and referring providers that are aligned with your enrolled beneficiaries if you're an access provider. So if you don't get referred, so if we go back to our little picture here, let's say a patient just signs up or you find them and you sign them up, you have an obligation actually to identify their care team. So obviously you can have a conversation with the patient who is their care team. And then you can also, this is where I think the claims information can also be very helpful and other sources of information. And I think also maybe the relationship with the HIE could help. I'd be curious if the HIE folks would like to weigh in on that. Understanding who the care team is going to be really important because, okay, I don't know what's happening there. Sorry, I had a pop-up. To making sure that you meet your obligation to identify the care team. So just wanted to mention that. So you've got to make your best effort to identify the care team. And then you need to, at care initiation, I think it's within something like 30 days of enrolling, of getting your Medicare beneficiary enrolled. You need to communicate the treatment plan about care completion. So that's also in a 30-day window, kind of on the back end of that 12-month period. And then they talk about some scenarios where you have something happening called care escalation. I'm not an expert on that. I mainly just wanted to communicate that there are 3 times that you're going to need to communicate at a minimum. Hopefully you're communicating more than that, but at a minimum, that's when you need to be communicating with the beneficiary's care team. And then finally, what are you communicating? Well, CMS is going to create a care plan and update template. We don't have the template yet, but they're going to provide a concise, standardized care plan, an update template that must be used, and they're just giving you examples of the kinds of things that must be in the template. Now, being an interoperability company that's used to dealing with things like clinical summary documents, we know there's a bunch of different types of those, and FHIR resources. I'm really curious what this standardized care plan quote template is going to look like. Is it going to be just a clinical document that you can put in a PDF and then you wrap it in some other kind of message for data sharing? This is a big unknown. So again, I'm going to go back to the group, and then our time is up. Oh my goodness. Okay. Sorry, folks. Usually I do a better job of watching time. We still have a lot of people on the call. This is really the last thing that I was going to talk about. So for those of you who can stay on, does anyone have any insights into any discussions around what this template might look like?
Hey, Marilee, this is Scott. I wrote in the text. I've got to drop for another meeting, so I'm gonna be late. But you talked about ACP at the beginning, advanced care planning. Advanced care planning is not an explicit requirement or a payment requirement under Access for a number of reasons we could go into. We're more of a this is more of a disease control outcomes program. Access is, as opposed to kind of it's active chronic condition management, as opposed to like crisis decision and end of life care and things like that. I dropped my email address. I didn't want to monopolize anything. My email address, if anybody wants to talk about that, about the RHTP strategy and how ACP fits into that, reach out, or I will be at the ASTP meeting. I'll be tagging along and shadowing Marilee because she knows everybody. And we'll be at HIMSS and the quality forum in March and all those things. So thank you very much. And I'll talk to everybody later. Thanks, Marilee.
Thank you, Scott.
Bye-bye.
And
Yep.
I want to call out that Reliance, our friends at Reliance, said that absolutely, yes, HIEs can help with the care team information. Wonderful. That is fantastic. Well, I will be respectful of folks' time. Sorry, ran a little over. Lots of information to cover. Really appreciate those of you who participated in the conversation back and forth. We will probably come back and revisit this topic as we get a little, probably mid-year, to just kind of see where we are. It was great to have all you on the call, and we look forward to having you attend the next office hours with us.
Thank you, Marilee.